Okay, let us start again. I know you might be very tired, right? I am exactly the same as you, but we can share something with this slide. Okay, I wanted to say, seeing is truth. You can see me, so I'm sure I'm here. You believe that? Okay. Some people think that our Earth is quite flat, right? So how could we stand like this if it is like a ball? People think that if we go forward far enough, there will be big fall. So like this, okay? So long time back, people think that we can go out just working, we can go to the universe, and then if you use some kind of boat, finally you will end up like this. And the people think like that. Star is here. Higher than that there is some water. Long time back, people think like that. Still, some people believe the Earth is flat. Some kind of the TV or something explain about the the Earth and the Moon. They think that is just a cheating. They don't believe, but we believe that, right? Long time back, almost all people think that Earth is flat, but nowadays maybe 99.999% people believe the Earth is like this, right? So people now stay and outside of Earth, and they got the photo like this. So now we believe that. So seeing is believing. Seeing is truth. But sometimes you can see A and B. Which is darker? A, B? Tell me. Okay, let us see. Was the same. Looks like you don't believe me. Please believe me. Same. How's that? Is it moving?
No, it's not moving. It's not moving.
Still moving? Okay, let us see. Still moving?
Yes.
Oh, okay. Okay, not moving, right? Okay. Is it possible? Interesting, right?
Illusion.
Could you see? Could you count the black dots?
Yes.
No.
How many?
We cannot.
Okay. So, seeing might not be true. Sometimes. So, a radar and a whole body scan, we cannot spend all time with those kind of imaging. So, is every area with the uptake on the whole body scan the thyroid cancer lesion? Definitely no, right? Other cause of the uptake, it could be physiology, it could be first pathology uptake, it could be contamination as well. Whether the whole body scan, with the interpretation of the physiological or other causes of radar uptake for the metastatic thyroid cancer could lead to the decision to perform unnecessary surgical removal or to give a high dose other than 131, which resulted in fruitless radiation exposure. So because of that, correct interpretation of the diagnostic scan is very critical for the proper management. Other than 131 and 123, 124 you can use. It depends. Availability. Anyway, the half-life, 131, 8 days, 124, 4 days. Is just half days. So, longer is a little bit better to get the specific imaging. But, for the patient's, comfort, maybe IDAN 131 might be better. Energy also important. The exam line energy from the IDAN 123 is 159. It's better compared to the IDAN 131. You know about that. Here is the advantage and disadvantage. Iodine 124 you can use for the PET nuclear instrument for whole body scan. You can use planar imaging, or you can apply SPECT technology. In case of the iodine 124, you can apply the PET-CT. Planar radioiodine whole body scan imaging has been mainly used for the detection of the metastatic thyroid cancer lesion. High energy collimator for iodine 131 because energy is quite strong, around 360. For the iodine 123, you can use less thick collimator. Limited resolution together with the background activity can give false negative result for small lesions. And the physiological uptake of the radioiodine is not always easily differentiable from the pathological uptake, and it can give false positive results. So we can apply the SPECT technology. SPECT provide cross-sectional scintigraphic imaging, and the SPECT have higher sensitivity and better contrast resolution than planar. The anatomical evaluation of the lesion site with the radioiodine SPECT only imaging remains difficult due to minimal background activity of the radioiodine. So you can use the integrated system, SPECT and CT, so you can see more clearly. PET, it detects a pair of the gamma ray produced by annihilation of the positron, which is emitted by the iodine 124. It also produces three-dimensional imaging, the same as the SPECT, and the better efficiency and the resolution than iodine 123 and iodine 131 SPECT, owing to its electronic collimation. You know about that, the annihilation, the gamma ray. So it's more accurate. So iodine 124 PET-CT can improve the diagnostic efficacy when compared to iodine 124 PET-CT. Combining CT is better. Already I explained that. Nowadays, the PET-MR is, we can apply, even if it's quite costly. So finally, I think that iodine 124 PET combined with the MR might be state of the art. Here is the imaging, the patient having the multiple metastatic lesion in patient with thyroid cancer with the metastasis. So for the scintigraphic, interpretation, we should know about this kind of things. The compliance with the low iodine diet. Contaminated with the iodine, maybe the sensitivity of the whole body scan will be lowered. And the level of TSH also important. And the history of the thyroid hormone will be lower, and the utilization of the recombinant human TSH we should know. Already I mentioned about the difference of the kinetics of the iodine by the elevation method of the TSH. Serum thyroid hormone and anti-thyroid antibody level is also important to interpretation of the whole body scan. And the description of the operative procedure also needed, and it's better to know about the tumor histology and others. And then when we interpret the imaging, it's better to know about the physical and finding and the prior history of the iodine treatment and prior the report of the iodine scan. And the history of the prior administration of the iodine contrast and the iodine containing drugs. And in case of the woman, menstrual cycle history and the pregnancy test and the nursing and the lactation history and the surgeon performing the thyroidectomy has sufficient experience or not. And in case of the thyroid cancer, metastatic lesion most commonly sit on the cervical lymph node. Second will be lung, or third will be the bone, and then mediastinum. The more lesions are demonstrated in late image than the early image due to background clearance, and the higher target to the background ratio. But for the late image, high radioiodine is required to get the appropriate image quality. In addition, we need to think about the half-life of the radioiodines. Iodine 123 half-life is just a half day, so you cannot get very delayed imaging. In case of the iodine 131, you can get the later, just because half-life is 8 days. Iodine 124 PET is good, just because the half-life is more than 4 days. Radioiodine whole body scan is not able to discriminate residual normal tissue and the thyroid cancer. You know about that. Image acquisition with the phenolcholimeter can better resolve in high intensity uptake lesion, and the SPECT CT provide better, more information. So this is that already we discussed with this case. Lady 21 years old and thyroid cancer, and the PET visualized the FTG uptake lymph node at the both neck. And the positive therapy scan revealed the intense uptake there, so we can tell the metastatic lesion in the lung and the lymph node. That's another case. You can see the difference of location and the multiple lymph node uptake at the time. Male, 34, paediatric cancer. Just here looks fine, but the iodine uptake revealed heavily metastasized lesion in the post lung. Quite a similar case, thyroid cancer patient. CT visualized very small lesions, but the iodine scan definitely it revealed intense uptake multiple lesions in post lung. Same. Another case, biliary metastasis. Same. Multiple lung lesions. Okay, this is that thyroid cancer patient, some lung metastasis and some mediastinal uptake as well. What is that? Give me 1 second. Here is that sinusitis, it's metastatic lesion. Nodule here. Okay, here is about the bone metastasis. Rather than whole body scan, you can see here, SPECT CT visualize the bone metastasis. Another bone metastasis, chest CT reveal mass in the sternum, and the other whole body scan, very intense, so the whole body scan doesn't localize quite well because of the star artifact. Too much iodine up there. Technician BD scan, it visualized the cancer lesion at there. Same location. Another case, female at 53, TSH stimulate T level is 34. You can see here, femur has a metastatic lesion. 65 years old female. You can see bone scan, uptake at here, radioiodine therapy, residual thyroid tissue uptake, and the metastatic bone lesion. Okay, this patient, we gave the radioiodine and the CAT imaging. You couldn't see any uptake at any normal tissue uptake in the body, just because the patient has very much metastatic lesion. It takes up every radioiodine. So I just draw the body figure. Here, cerebellar metastasis. This one is chest wall metastasis. This one is a pelvic metastasis. Those are lung metastasis. This is spine metastasis. Too much metastasis. So thyroid cancer can go everywhere. So this radioiodine orbit metastasis, radioiodine will go there and we can detect that. But in case of the radioiodine non-orbit metastasis, we cannot find that with the radioiodine. Metastatic nodule in the chest CT, but we couldn't see any iodine uptake lesion in both lungs. The same. Quite a similar case on technician mid scan, you can see focal accumulation in the mediastinum. Chest CT revealed that the nodule at the exactly same site of the BB accumulated site, but the iodine scan, nothing. So surgery was performed, and the result was the thyroid cancer metastasis pathway type. So let's go over. As I mentioned at the beginning, seeing is true, sometimes not. So some regular iodine uptake might not be related to the the metastasis of thyroid cancer or thyroid remnants. The physiologic activity is expected in the thyroid tissue. You know about that. And the salivary gland, stomach, breast, oropharynx, nasopharynx, esophagus, and the GI tract, and the general tract. Sometimes physiologically, radioiodine accumulate will be happening there. So physiological radioiodine accumulation is related to the expression of the NIS or radioiodinated substance, or related to the inflammation, or to retention of the excreted iodine. Excuse me? Thymus. You will see. You will see soon. Give me 1 second. Okay. So this is just the physiological take. Choroidal plexus, lacrimal sac, nasopharynx, and the salivary gland, and the oral cavity, in the esophagus, and the breast at here, and the liver, and the biliary tract also. You can see that. And the large bowel you can see, and it will wash out using the urinary system. So you can see the kidney and the urinary tract, and the ureter, bladder as well. Okay. So physiological radioiodine uptake, it is not uncommon to have intense trace uptake in thyroid fat in initial radioiodine whole scan because of the residual thyroid remnant is quite much, so which will produce star artifacts. So precludes clear visualization of the neck. You experience sometimes this kind of things, right? So some metastatic lesion can be hide this star artifact. In this patient, you can see some lung uptake. The patient has the lung metastasis. So if you encounter this kind of thing, you should get the later imaging, and then you need to find out the metastatic region. Or after ablation of the normal remnant, you can give the diagnostic radioiodine, and you will see. Okay. So this is table. Physiology radioiodine uptake. The residual thyroid tissue, definitely this is expressed in this, right? So ectopic normal thyroid tissue, it can localize in the just the sublingual area. Sometimes ectopic thyroid tissue can be found in the mediastinum. And intratracheal, paracardiac, intrahepatic, all reported before. Definitely, because of this is ectopic normal thyroid, so this is the reason. Salivary gland, it also expresses NIS, so we can see easily carotid and some mandibular glands. And lacrimal sac and the nasolacrimal ducts, it also expresses NIS. But some controversy is there. So some people think that it is not related to that, just because the what's that? Lacrimal gland excrete iodine, so we can see the lacrimal sac and this duct. And the excreted saliva and the swallowed saliva. Because of that, we can see the oral cavity and the esophagus sometimes. Okay, here is the thyroid remnant. We quite familiar to this as thyroglossal duct. It's quite popular, and you can see this is thyroid bed, but it's quite far from the leg area, so it's a little small goiter. Now you can see here aorta here. So salivary gland, quite a typical one. And because of that, after therapy of the iodine 131, patient complain about the xerostomia. Okay, nasomacromegaly, sometimes we can see that. The asparagus, we can differentiate it with this one from others by the swallowing of the free water. We can watch that one. Okay, nasal secretion, it makes a hot nose. You experienced that before. By the excretion of the urine, you can see renal pelvis, urethra, urinary bladder, and urinary tract diverticulum, urinary tract fistula, renal cyst sometimes. And then active radioiodine by the expression, this can be another mechanism. Some people argue for that. And the choroid plexus, it expresses this, and the thymic uptake, the thymus, expression of this in the thymus tissue and the iodine concentration by the host body, it is reported. As I mentioned before, sometimes the migration of normality of the normal thyroid tissue can be localized and can be located in the thymus. So sometimes we cannot differentiate it, but this abnormal ectopic thyroid also taken up the iodine at there. Thymus itself can express this, but the intensity might be less than that. Gastric mucosa, it expresses sodium and symphora. So stomach and Meckel's diverticulum located in small bowel, it also can take up the radioiodine. So hot nose here, hot nose here, paraglossal duct here, remnant here. It's oral cavity, just the excretion. If you combine with the spasticity, you can decide accurately the reason of the uptake. Okay, thymic uptake. In younger people, maybe you experienced that one. So people believe that the thymus express some this. Okay, you can see the thymus here and the stomach uptake because of this expression in both organs. Stomach uptake, quite usual. Okay, this is that Meckel's diverticulum, it uptakes. Okay, you can see urinary bladder and the urine contamination, quite usual, because of the iodine will be excreted in the urinary system. Salivary gland express sodium and symphora, it will take up the radioiodine. Renal cyst, okay, it can take up. So people think that the uptake in the iodine in the renal cyst is that related to the communication with just the urinary system. So some people think that it is just the localization of the iodine high urine, but some people think that the renal cyst epithelium can express this. So both might be possible mechanism. Here, renal cyst. Other physiological uptake by the excreted gastric secretion, so you can see some bowel uptake and the metabolism of the radioiodinated protein. So you can see the liver, biliary tract, gallbladder, and the bowel. Let's see this metabolism of the radioiodinated thyroid hormone or thyroglobulin and their excretion into the gallbladder, bowel, through the biliary tract. So we can see that. So breast, rotating, especially breast, it has the expression of the sodium and symphora. So some people think that the breast cancer also can express sodium and symphora. So a couple of researchers working on that, and they want to treat the breast cancer with the radioiodine, applying some drug which can enhance this expression at the breast cancer lesion. Colon, usually diffuse, but sometimes focal. Okay, I see the liver uptake. Some people think that after treatment of the thyroid cancer using the radioiodine, if there is some uptake in the liver, people think that it might be successful therapy. because that the reason is that radioiodine went to the thyroid cancer, hidden cancer region, and that is incorporated in the cancer region, and finally it excreted the iodinated protein from the cancer, and finally it metabolized in the liver. So higher uptake in the liver at the therapy of iodine 131, people think that the therapeutic effect might be good. If no definite uptake in the metastatic region even. Okay, gallbladder uptake we encounter sometimes. And the breast uptake, definitely you can see the breast, it is the lactating breast. Same, breast uptake, gastric uptake, salivary gland uptake, or related to the expression of the sodiumide symphosa there. Just a simple difference between the thyroid cancer and the metastatic lesion and the remnant from the other organs such as the salivary gland and the stomach is that the TSH dependency. In case of the thyroid related tissue, remnant and the normal thyroid tissue and the thyroid cancer tissue, that is the dependency of the TSH. So because of that, we recommended human TSH or try to increase the endogenous TSH by stopping supply of the thyroid hormone. But other organs, salivary gland and the stomach, it doesn't have any dependency on the TSH. Okay, breast uptake. SPECT CT revealed the breast uptake. Colon uptake. We should tell the patient should have laxative and remove out that uptake at there to reduce the fruitless radiation exposed to the large bowel. Colon uptake as well. Okay. So far about the physiological uptake. From now, we will discuss about the pathologic lesions might show false positive radioiodine uptake. A variety of the pathologic lesions produce false positive radioiodine might be tricky enough leading to some patients undergoing unnecessary invasive surgical or high-dose radioiodine treatment. Not uncommon pathologic lesions showing radioiodine uptake are cystic, inflammatory, and non-thyroidal neoplastic disease. In case of cystic lesion, the mechanism is the passive diffusion of the trace into the cyst. Inflammatory and infectious disease, it might be related to the increased blood flow and the permeability increases. Other non-thyroidal lesion, it might be related to disease expression or increased blood flow and permeability as well. Excuse me? Yeah, you can see the same. In the case of the, excuse me? What circulation? Enhance the circulation. I definitely needed a hearing aid. Tell me once again.
I saw a iodine uptake in one cancer. I saw a iodine uptake in one cancer. Some people.
Lung cancer.
One cancer.
Lung cancer.
But they explain that by delayed circulation in this region. So iodine stays there for long time.
Okay, got it. You mean that the lung cancer it stays longer because of the lesser washout from there? And that's possible. At first, cancer it usually takes much blood flow from the other compared to other body. So at first, high level of the radioiodine will arrive at there, and then it will just extravasated and then located at there. So less concentrated iodine, blood with the less concentrated radioiodine will wash out there. So finally, the cancer lesion will have a little bit more. So it's same as that increased blood flow and the permeability. That is exactly the same. Thank you. Okay. The heterotophic thyroid tissue, in case of a stroma ovary, you know about that. So definitely because of this. Other inflammation associated with or without infection. So many things: pericarditis, skin burn, dental disease, arthritis, cholecystitis, folliculitis, sinusitis, dacryocystitis, bronchiectasis, and fungal infection, and pericardial effusion as well. Everything related to the increased perfusion, vasodilation, and less washout from there. So, periodontitis, you can see. I'll take it there. And this is the thyroid remnant. It's odontitis. You can see chastity, bronchiectasis lesion here. Okay, it's that anterior projection. Okay, it's right lateral, it's left lateral. So bronchiectasis can take out. We cannot tell it's the metastasis of the thyroid cancer to the lung. This is that patient with the pulmonary aspergilloma. You can see the fungal ball at here, very crescentic type of air. So fungal ball also can take up the radioiodine there. Other pathology radiation take cystic lesion, bronchogenic cyst, and the renal cyst. People think it's an unknown mechanism. It might be related to the mixed expression or just the diffusion might be the reason. Non-thyroid neoplasm, so many types. Sometimes it expresses this, and even if it doesn't express this, it also could have a chance to get the radioiodine because of the increased blood flow and the increased permeability in the tumor. And the trauma, Bob's-site, tracheostomy-site, iodine can accumulate there because of the increased perfusion and the vasodilation and the increased permeability as well. That's a patient with the bronchogenic cyst. Here you can see the high uptake. Chest CT revealed some lesionette here, so we performed the surgery. The final result was the bronchogenic cyst. The third one is the contamination. External contamination by physiological and pathological body secretion causes positive radiation uptake, sweat, breast milk, urine, vomitus, and the nasal and the bronchobronchial and the lacrimal and the salivary secretion, feces all contain radioiodine. So their contamination to the hair, skin, clothes can be misinterpreted as metastasis of thyroid cancer. False positive scan by contamination can be kept to a minimum by careful preparation of the patients, such as the image acquisition in a clean gown after taking shower. Contamination are most always very superficial. Because of that, the use of the lateral and the oblique view or aspect to give a third dimension to the scan may help to identify the contamination. Clear saliva, sweat, vomitus, breast milk, urine, and feces. Site of uptake, skin, any part of the body, hair, wig, clothes, mechanism, contamination. So sweat, here, nasal secretion, saliva, breast milk, gastric excretion, vomitus, feces, urine, all can make the contamination. You can see intense uptake by the high amount of residue, but you can see the lateral imaging. Almost the backside, quite superficial. This is not the lung metastasis, it's just a sweat. Contamination by the saliva. Here, it's anterior projection, it's posterior projection. After washing, you couldn't see any residual uptake up here. Contamination by saliva and sweat, you can see outside of the body. It's a hair contamination. Iodine just contaminated to hair. This one is just a sweat. Multiple place contamination, arm, thigh, foot. You can see here, here, hip. After washing, you couldn't see anything. Okay. Contamination by sweat and urine. You can see diffuse and the urine uptake. After washing, very clean. Okay, here saying contaminated by saliva. After washing, it will go away. Contaminated by urine, and this is the activity at the colon. So after the defecation and the washing, nothing was there. So today we discussed the physiological uptake and the contamination. For the physiology, corrosive plexus, lacrimal sac, basal pharynx, salivary oral cavity, esophagus, lamina thyroid, breast, liver, biliary tract, gallbladder, kidney, adrenal pelvis, ureter bladder, right bowel, and the contamination, any place is possible by the sweat. Here, beta secretion, saliva, milk, gastric secretion, vomitus, feces, and urine. Okay, we know the whole body scan is quite powerful engine to detect different thyroid cancer. As I mentioned before, radar whole body scan, radar scan is the only way to predict possibility of the response by the application of radar 131. So it is quite valuable. Because of that, okay. One problem of the whole body scan is that we cannot differentiate the different thyroid cancer from the normal residual thyroid tissue. Because of that, there are difficulty to differentiate the reason of the focal cervical radioagnostic, because remnant is quite prevalent after surgery after the neck. So, okay, let's look at whole brain energy, right? Let me know about your thinking. What's that? Is that remnant or metastatic lymph nodes? Tell me. What's that? Thank you so much.
Because it's written down.
You're too clever. Okay, now you couldn't see. What's that? Already you recognize. Okay.
This is more difficult because question mark.
Okay, you can tell. You can tell.
Both. I cannot appreciate.
Okay. You think that's the lymph node? Could be, right? So because of that, we should do the SPECT CT. It's synergistic combination of the function and anatomical information. So better diagnostic efficacy compared to plain eye imaging. So let us see. We know about that. So already we know about this, right? It's remnant. It's definitely metastasis. That is an issue. Here, definitely, just in front of the thyroid cartilage, so it is a remnant. As you can see, very lateral parts, multiple, so it's a remnant. This one is not, attached to the trachea area. It was lymph node metastasis. PG also give some information. Before starting of the interpretation of the whole body scan, I told you that we need to consider others such as preparation method and the PG level and the previous history and the other imaging study result as well. So this was based on my memory. I think that the PG level is more than 300 in this baby. This is quite young, less than 10 years old, younger than. So SPECT is quite useful in case of the differentiated as the remnant from the metastatic region. Okay. Here, you can tell it's a remnant, right? Just attached to trachea area. This one, remnant. This one is definitely lymph node metastasis. SPECT CT visualized each lymph node having the radial and uptake. This one, same lymph node metastasis. Okay, this is nothing. It's the same. The same patient, lymph node metastasis. You can definitely see lymph node metastasis right here. Okay, you remember this is that the lead with the expert. I think that all of you are expert, so I am leading with you. So, what is your thinking about this and that? It could be remnant. It could be lymph node metastasis. You agree? Any other possibility? Okay. Tell me. Excuse me? I'm talking about this. Okay. Lymph node, or maybe remnant, or maybe what? What? Okay, it doesn't look like lymph node. Okay. How about this? It could be, diffuse liver uptake, but at here a little bit more. Is that liver or bowel or gallbladder? Good, and thank you. Let's go ahead. Okay? This is the SPECT image. This uptake. What's that?
This is intrahepatic.
Intrahepatic. Okay. So many assumptions could be applied. Okay. SPECT CT visualized, it was gallbladder. So we have to do SPECT CT, okay? Okay, let's go upside. What's that? Our preliminary assumption is that it could be lymph node metastasis. It could be residual side of the remnant. Okay, it was gallbladder. This one, SPECT, you can see quite intense. SPECT CT reveal it located inside of the lung. Even CT component visualize a small nodule right there. So final diagnosis was lung metastasis. So without SPECT CT, we cannot tell. Thank you so much for joining. It's had nothing. Okay, already I summarized almost everything during my presentation. Finally, I wanted to say thank you so much for spending your invaluable time with me. I enjoyed quite much playing with you. And have a nice day in additional 10 days in Korea. Thank you.
Thank you for the wonderful trio of lectures. Enjoyed them very much. I have a question. Do you think the SPECT and the CT registration is good enough that you can find